Our final presentation is on clinical practice-based programs, strength after breast cancer. Kathryn Schmitz, Penn State College of Medicine.
For those of you I haven't spoken with in over 6 months, I moved. I'm no longer at Penn, I'm at Penn State. So it's the big green button. I've heard that a couple of times. Let's see if this works. Before I get going, I'll just briefly say that I know tomorrow I get to wear my ACSM hat for more official terms in another session, but I will say, just in light of how many times it's come up today, that we do have two ACSM representatives here today, Jane Sr. and Monty Ward. Monty is outside. And we are planning the next ACSM roundtable that you've seen quoted about here today. And one of the key issues that we will be dealing with is triage, is this issue of screening. And in fact, we're doing so. We're developing it in partnership with APTA. Steve Morris is our rep from APTA helping us, and AAPM&R, as well as several international partners, including ESSA from Australia and the Macmillan group in the UK and others. So stay tuned, that's coming. But there will be a big discussion, and I think part of the question that I would ask this group to really think about is scope of practice, because I do believe, and I'm going to present some of that today, that the population-based approach or YMCA approach is not right for everybody, and the clinic-based approach is not right for everybody. And we need to do a better job of deciding how to triage people from one place to another. So I'm going to jump right in, no introduction slide here, to say that I'm talking to you about an evidence-based program that I have disseminated. We now have it in over 380 locations across the country. But it started with the Susan Komen Foundation grant called Weight Training for Breast Cancer Survivors that I did when I was a new investigator back at the University of Minnesota. This study had 85 people in it, and we started with 13 weeks of supervised training led by ACSM certified exercise professionals for 13 weeks, and then 13 weeks on their own. The lymphedema outcome at that time was about circumferential measurements on the affected versus unaffected arm, and my doctoral student at the time, Rahana Ahmed, published a paper in JCO back in 2006 showing that weight training conferred no risk for lymphedema onset or worsening, which was quite contrary to what we knew at that time over a decade ago. So that was the basis for what many of you in the room now know as the Powell Trial, which was funded by NCI as part of the Long-Term Cancer Survivorship Initiative. This was a one-year-long randomized controlled trial of weight training for breast cancer survivors. By design, half of them entered the trial with lymphedema and half entered the trial at risk for lymphedema. We did have a substantive proportion of our participants who were Black women. This was done in the city of Philadelphia. We did the intervention at YMCAs with YMCA staff. I did that on purpose because when we were done with WTBS, it was very upsetting because we had a lot of media attention and I had hundreds of phone calls from people asking for the intervention, and I had no way to give it to them. So this study was truly designed with dissemination in mind, and we thought, okay, so we'll teach it to YMCA trainers because there's a wonderful tradition of training at the YMCA, and we thought, okay, this is going to work. This is going to be great. And you can tell by the way I'm saying that it didn't work out that way for us. And I actually was doing this as Live Strong at the Y was getting developed. I was part of developing Live Strong at the Y. I love Live Strong at the Y. So it was just broke my heart that this particular program didn't work that way. Anyway, what we did to train the staff in the Powell Trial was 3 full days, 24 hours of training them. We trained 17 staff in 8 different fitness centers, 4 different YMCA associations, and we were with them at least once a week to make sure that they were doing what we asked them to do with the protocol. And the main results were published for the women with lymphedema in 2009 in NEGM, and for the women at risk for lymphedema in JAMA in 2010. And then since then, we've published that we had benefit for body image and sort of their own sense of their strength and ability, for quality of life, for skeletal health, so this was a bone health outcome, as well as for protecting physical function most recently. There are other papers in the works, but summary of findings, we did show, as has been noted earlier, some benefits for lymphedema, as well as strength improvements, body image improvements, prevention of decline in functional status. So we clearly have an evidence-based program here, right? So what we also did, and this has been spoken about already, is a laundry list of things that we were doing to protect these women, to ensure that they were safe. There were full FTEs funded by an R01 from NCI to ensure that these women were adequately screened. Some of them had lymphedema, and we knew it to come in. This is not a walking program. This is a progressive weight training program, okay? So in order to try to get them to be stronger and substantively stronger. So we did all of these things, and what we started to recognize was that based on my experience with, I actually got to go through the whole program of learning how to do Live Strong at the Y with the Burlington County YMCA in New Jersey, and I was really clear that they were not going to be able to do this. They were not going to be able to do this for this program, okay? So the question then becomes, who would do this outside of the realm of a research study? There's no current infrastructure for doing this within our oncology clinical settings or within fitness centers for a program like this. So we decided, after looking at the options, to use what we have. What we have in the United States for this kind of program is the setting of outpatient rehabilitation. And so we decided, okay, let's go there. Let's see what happens if we translate it into outpatient rehabilitation. So we reinvented Powell. It became Strength After Breast Cancer. Ask me sometime why it is not called Powell anymore. I won't belabor it because I see my counter. But it starts with a referral from an oncology clinician, and then they go through an evaluation with a physical therapist, just like we did in the Powell trial, and then they do an education session. Interestingly, the education session is actually the exact same education session that is required of all YMCA staff when they become certified to deliver Live Strong at the Y. It's the lymphedema education session. And then we had them do 4 group physical therapy sessions to learn the protocol. I insisted, as we were designing this dissemination implementation study, that we keep the group sessions because they got so much social support and they liked the group sessions, okay? The participants did. We then gave them a choice, and the women who were in the study and since then have all been given this choice, and we stopped the choice after a long time, after about 1,000 women had done the program, because if we gave them the choice of home-based equipment, adjustable dumbbells, you know, of various different sizes, or a 3-month YMCA membership that was paid for them, not one of them chose the YMCA membership. That doesn't mean there aren't people that want to go to the Y. That means these women didn't want to go to the Y. We debated heavily, should we make this a self-pay activity or should we try to take it through insurance? And we went back and forth and ended up saying both. We did both. So the whole thing cost $416 at the University of University of Pennsylvania's outpatient rehab clinics. But we also allowed women to go through their insurance. And we decided to do that because the main clinic that serves the University of Pennsylvania for outpatient rehab serves West Philadelphia. West Philadelphia, born and bred. Yes, that West Philadelphia. So it's a very, very heavily African American community, and most of the clients there are on some kind of aid, Medicare, Medicaid, or charity, coming to physical therapy. And so as a result of taking it through insurance, we ensured that low-income individuals were able to go through this program, and that did work. So that's a huge success. We developed trainings. We developed a training for oncology clinicians We taught them how to make the referral. We gave them all of the information we thought they needed in order to be able to make the referral. We set up what we called a 3-click solution in Epic, so they could click 3 times and they'd made the referral. They really couldn't do it very well, interestingly. They actually had a really hard time with getting it done, but the oncology nurses picked up the slack. The physical therapists noticed we said 24 hours to train each of the fitness trainers at the YMCA. And the thing is, of the 17 trainers that I trained in PAL, only 2 of them still work for the Y by the end of the study. So there was a little bit of a sort of a Sisyphus pushing the rock up the hill issue there. So with the physical therapist, 2 to 6 hours. If you have turnover, at least it doesn't take quite as long. We did land on 4 hours after changing the training length. So I'm not going to belabor every single line in here. What you look for in the dissemination and implementation science study is whether you're able to demonstrate that the safety and effectiveness is maintained after translation into clinical practice. And we were able to demonstrate that for the outcomes that were measured in our D&I study. We used the consolidated framework for implementation research as our method for evaluating our implementation. We did qualitative assessment using direct observations and semi-structured interviews with oncologists, oncology nurses, physical therapists, patients, front desk staff people, and there are 5 domains in CFIR. We evaluated 4 of the 5. The first one we evaluated was intervention characteristics, and what we found was that group PT did not work because that's not the way PTs practice. And so as much as the women liked it within the Powell trial, they didn't like it and in the Y, they didn't like it at the PT because the PT didn't know what they were doing and it just didn't work for them. So we revised that for them over time, and it's now individual PT. And then the outer setting is the way that the CFIR framework talks about how the patient experiences the intervention. And we learned a number of things there. One of them was that patients do not view exercise as medicine. Sorry, ACSM, but there it is. So they didn't view it as medicine in that if a doctor says you're going to take, the following chemotherapy regimen, the patient doesn't say, no, I think I'd rather do Pilates, But when you say, okay, we have this program we're going to refer you to, it is evidence-based, and, a scientist thinks that you should do this, and so do I, I'm your doctor, they say, that's nice. I have this Zumba class I take, or no, I'm a power lifter, which makes me very nervous. So they don't view it the same way. So we do need to have Live Strong at the Y and Strength After Breast Cancer and phone lines and walking programs. We need to have all of those. One of the other things that we learned is that patients are not particularly good at self-triage. So the people who should really go to Strength After Breast Cancer and should be afraid because they've had 18 lymph nodes removed and they are at high risk for developing lymphedema are not necessarily the ones who are willing to go to rehab. The other thing is many of the women who really would have benefited from going said, no, I don't need rehab. So we have a real stigma around rehab in this country. I think when I think rehab, the first thing that comes out of my mind is, drug rehab, right? So we might need a new word or something in dissemination of all of this. Another issue was cost and location are major issues. People will travel an hour and a half or 2 to get high quality cancer care for curative care, but they're not going to travel in order to get to a YMCA that's too far away. They're going to want a phone program. They're going to want something really close to their home. Cost was a huge issue, and having insurance coverage was no panacea. We discovered that for physical therapy, there are many insurance companies that have extraordinarily high copays for physical therapy specifically. We were shocked to find that we had people who had catastrophic insurance just for physical therapy who got bills for thousands of dollars, and we had to back into the self-pay. So, and one of the difficulties there is then the front desk staff, how are they supposed to know which one the person has? So it's not simple. The inner setting, the clinicians had a difficult time finding time to make the referrals, and then they actually had difficulty with the referral process in ways that we had never anticipated. So the story I love telling is that the group that does reconstructive surgery claimed that they were referring every single patient. Wonderful group of clinicians, caring group of clinicians. Not one of those women was making it through the door of the outpatient rehab clinic. So we went back over there and sat down with them and said, what are you actually doing? Show me what you're doing. And they went click, click, click. They said, I've made the referral. And they didn't seem to understand that they had to print out a piece of paper and hand it to the woman, because in all of the rest of the referrals from their reconstructive surgery group, if they were referring to someone, wherever they made the referral, there was an active follow-up. So that made us then say, oh, wait a minute, active follow-up, that might be good. So we actually went back and did exactly what Karen was talking about earlier, and we looked to see what proportion of women who were actually handed a piece of paper showed up, and the answer was 35%, which is better than, better than the quit line. But when we did active follow-up, which is to say we sent an email to our PT champion to say, please call this woman because she's gotten a referral, 69% adopted the program. So huge, huge issue there. Implementation approach. Changing clinical practice is really hard. It doesn't matter whether it's PT or someplace else, but in PT, it was really important that we have a champion, because if we had not had that champion, all of the confusion that happened at the beginning when we were insisting on group PT and all of the confusion about the front desk staff people, scheduling people for the next session of Strength After Breast Cancer, not realizing that session 1 was not the same as session 6, right? So all of that, if we hadn't had a champion, they would have said, forget it, we're done. So having a champion is huge for implementation. So this is now a clinical program called Strength ABCs. It is covered by insurance. Sorry, it's kind of exciting to have that happen. We have over 90 ICD-10 codes that can be used to get this paid for. We have yet to have anybody tell us that it's not getting paid for. I'm happy to go through this in detail with anybody who has the time later. And the training for this, the next question was, okay, how do we make this happen all over the place, not just at Penn, right? So I started a small company. We tried to make it happen through, I was going to go around the country and do this. It didn't work. And then I learned from my PT colleagues that they do their continuing education credits online. And so I went to work with Günter Kloos, who runs a consulting company that does education for outpatient rehab, and in particular around lymphedema, because that felt really appropriate in this situation. We made the training. It went live less than 2 years ago, and I actually called during lunch to say, where are we? How many have done it? 387 physical therapists have taken this training at this time, and it only costs $125. So clearly this is a way to get this thing out there. We do have another, this was an R21 that we did, and we do have a DNI R01 under review in order to compare whether this approach in a commercial rehabilitation setting in little towns all over central Pennsylvania will work better than or the same as a DVD version of the Powell intervention that we've developed. We also, I'm very proud to say, have opened an exercise medicine unit in the chemo suite at Penn State Cancer Institute, and we're starting a trial within a week or two called ENACT. This is D&I research, because one of the things that we all know is that the people who come into our trials are healthier than the patients that are not coming into our trials. And so one of the questions that needs to be asked of all of us is, what do we do for the patients who did not have the self-efficacy or ability to make it to the Y, to Strength ABCs, to whatever other programming we are offering them at this time? And I think I'll say thank you, and that it obviously takes a village to do this kind of research.